because I was on the other side of the fence, so to say. I don't like fences, but I was on the other side. I was a specialist for about 28 years. I was a clinical oncologist working in various centers. I used to get a lot of referrals from all of you, and we used to be sitting in the ivory castle called a hospital, and we used to pontificate, and we used to treat, and we used to give decisions, and we used to be busy doing what we specialists normally do. After about 28 years or so, I realized that the time has come for me to go back and see if I can do something different. And there sprung this idea of home health care, because palliative care, end-of-life care, etc., which I dealt with extensively, I realized there is a crying need for doing something at the level of the community, at the level of the home. And making your fancy plans in hospital need not necessarily mean they're executed. And I noticed there were a lot of dropouts, compliance issues, adherence issues, and realized that the missing link needs to be addressed. And there was born this idea along with a few friends of mine. We've been operational for the last 2.5 years now. And I think doing something like about 60,000 visits a month over 24 cities in the country is testimony to the fact that maybe we've hit the right combination. And I'm going to share this particular journey with you and tell you how wonderfully well we can complement family health and home care as an integral part of doing non-tertiary care work, so to say. Very simply put, home health care is anything what you can do at home without disturbing the internal atmosphere of a patient's mind and residence. Anything at all which can be delivered at home, because the alternative for this is no care at all. Or the other extreme, go to a hospital, which beyond a point in time, patients would rather not take any treatment than take that particular option. And why is that? There is this cost factor involved. Cost not necessarily in terms of dollars and cents, rupees and paisa, but cost in terms of time, cost in terms of patience, cost in terms of attrition. There is it's a very slow and stressful process in a hospital. This is how a typical government hospital OPD, or maybe I was in Medanta Hospital yesterday. This is how it would look, and it would be an appointment at 10 o'clock. You'd be lucky to see somebody at about 11:30. The meeting would be exactly 3, 4, 5 minutes, and then you're off again, coming back to your house. By the time you come back at late evening, and God forbid if you are 60 plus, you have various special issues to address, and that is not addressed. Therefore, it becomes extremely stressful. And this is not to our people who have come from outside the country, this may look funny, but for people like us in Delhi and Bangalore or Hyderabad or Mumbai, this is very, very common. We factor in our travel times. When I leave my office at 5 o'clock, I get home at 5:30. If I leave my office at 6 o'clock, I get home at 8 o'clock. So I'd rather sit in office till about 8, do my work, and then go home at 8:30, rather than get out on the road at 6 and go home at 8, not to mention the fumes and the stress and the various other problems involved. So this is a fact which you can't wish away. We are not in a position to make decisions. Somebody was talking about infrastructure development in the morning. I'm looking forward to that. But till such time, visiting hospitals is sometimes terrible. And this is a statistic which we can't wish away. The hospital patient bed ratios in our country are awfully abysmal. And we have a long way to go before we do all that. Mr. Desuraju touched upon this particular point in the morning. And if nothing in the transition, maybe home health care and primary care can to a certain extent stem the rot, bridge the gap. These are some of the scary statistics, the kind of needs that are going to evolve over time. We require phenomenal number of medical personnel, double the number of doctors, for example, triple the number of nurses, and about 4 or 5 times the paramedics. So we are really scratching at the bottom of the barrel to meet our ends in the next 15, 20 years. Therefore, this seems to be a tangible alternative. Lower rates of infection for very obvious reasons. You're all doctors, you understand. Nosocomial infections are avoided. Faster recovery because the patient is in a situation where he's comfortable with sleeping, sitting in his favorite bed in very familiar environments. And the treatment is more holistic because monitoring is far more one-to-one, Identifying new problems is easy, and a bond develops between the clinician and the patient in a home setup. And I'm not just talking through the top of my hat. There are statistics to prove that people who have taken home care or have a robust home care system have less inpatient days in a hospital. This is called A-loss reduction, or average length of stay reduction. And just reducing the hospitalization days are not important. Ensuring that the patient don't come back with the same ailment for a readmission is equally important, and very amply demonstrated in this slide. Home health care reduces inpatient days, at the same time reduces readmission days. And that means health factors, cost factors, optimization factors all put into one. Now, what happens if you analyze about 100 patients who are sitting in front of your OPD in a hospital? Half of them, I believe, are for very, very trivial reasons, like they want to follow up on a visit, they want to show you a prescription, they've been given a generic drug as in contradistinction to the drug you prescribed. They want to know if it is the same drug, the same family of drugs. They want to show you a lab sample report. They want to know if the physiotherapy is available. Are they coming for a physiotherapy on a day-to-day basis? They have a dressing change. They have a clarification. They want to check with you about that. And they want to take a minor injection. They don't know where to go. You are the person who prescribed it, so they want to come and show it to you. They seek various clarifications. They want clarifications on equipment and so on. Therefore, we have unnecessary footfalls in the hospitals. What it does is it's counterproductive in the sense that you're not giving enough time which the patient thinks you ought to give them. At the same time, precious medical resource focused on what a hospital is meant for treating emergencies or specialized care is not given. Disgruntlement all over the place. This is more so for elders and patients who find this very, very inconvenient. The various indices, I will not touch upon this, you are all very familiar. There is home care brings down cost, ambulatory surgery brings down cost, rehab centers bring down cost when compared to the care of the same care at a tertiary care hospital. All right. So to summarize briefly about what I said so far, elective patient monitoring instead of symptom-based monitoring, which happens in a hospital, reduce the incidence of complications all around. Even though the care may not be super, there is average or above average, you maintain that and leave the rest to the home care environment to heal itself. Detect impeding complications because we are at it all the time, and we have plenty of time to talk to the patient and give them the counseling. So they come forward and tell us even the minor kind of situation they have, which may be important, non-important, but I can digest that particular data. The bottom line is we increase the compliance. Compliance is one of the biggest reasons why we have various complications for various disorders. And like I said earlier, useful in elderly, homebound, or comorbid individuals who otherwise would not have taken any treatment at all. And we are living in such a nuclear world today. The patients are in their homes in Bangalore, let's say. The children are working in Delhi or Mumbai. They're very, very concerned. Some of them even go abroad. And they are so concerned, especially when they are far removed from their parents, the concern goes 4 times more. And we can be their surrogate caretakers, keeping them in the loop and making everybody feel comfortable. What are the services typically we can offer? We can ask for doctor consultations at home. We have a whole lot of MBBS level, basic level, GP level doctors with 3 or 4 years experience who have grown with us, who can do this eminently well. We don't take emergencies. We are a bridge between the doctor in a hospital and the home visit. We can do nursing services at home. Physiotherapy is eminently doable at home in almost 80% of cases. Today, physiotherapy is no longer the physiotherapy of very elaborate instrumentation. Physiotherapy today is more manipulative and more exercise-based. Nursing attendants at home, especially for the elderly, to do ADR activities. Lab tests at home, just to take a sample of blood, one need not travel miles together, not even sure what kind of labs are going in. We have accredited NABL labs coming home, collecting the sample. And we can also sometimes give medical equipment for special needs, a waterbed maybe, an airbed maybe, a wheelchair and things like that. We can certify that the product is good, it may be for long term, for outright purchase or whatever it may be. We are providing a one-stop shop for everything possible at home. Some of the typical procedures we do, any kind of instrumentation in terms of catheters, nasogastric tubes, cleaning all these, reinserting them, flushing them and so on. All kinds of stomach care is possible, tracheostomy, colostomy, and ileostomy. Being an oncologist, I train all my staff as to how to handle this at home. Compliance in drug delivery, we have various designed models and questionnaires to find out what kind of outcome measures are there, how to assess the quality of drug intake, what kind of dropouts there possibly can be, chemotherapy port flush or a catheter flush, all kinds of wound care, drain care, dressing, staple removal, suture removal of a very minor nature. All these are possible at home, and we've been doing this for the last 2 years. The impact of the whole thing is very, very widespread. Patients feel comfortable. Hospitals are very happy, paradoxically, that we're doing this because a lot of irritants and clutter is out of their way. Pharma, refills, etc. are very, very convenient. And the most important of them all is insurance have reduced payouts. Unfortunately, unlike in the US and perhaps in other countries, insurance is not so robust in the home care sector. We are very actively chasing various insurance people to recognize home care as a very tangible model. Unnecessary admissions in hospital just for the sake of insurance is very common. I have to give a 1-hour infusion for a cancer patient perhaps. I can't do it at home if the patient is insured because the insurance companies does not recognize home care therapies. The patient has to travel 25, 30 kilometers, come to a hospital. They're very low priority for an infusion, believe me, in a tertiary care hospital. Nonetheless, they go through the process, go through the elaborate billing. For an 1-hour infusion, they come at 9 in the morning and leave at about 6 in the evening, which I think is absolute rank misuse of optimized home care. I will illustrate this whole example by giving 2 examples. One is in the area of geriatrics, and other is in the area of a chronic ailment like diabetes. Home health care has transformed geriatric care in India. There are so many elders who would never have gone to a hospital to seek medical attention but for home care. So we opened up a new window for this population, and more than anything else, it is the care which our clinicians go regularly and give them. Many of them share a cup of coffee with our clinicians and talk about a whole lot of things and open up this particular sector for meaningful geriatric care. And young India is no longer young, and the way the population is getting healthier and the increasing numbers in population, we envisage a large burgeoning population of 60 plus, about 5 or 6 times more in the coming years, and that means we have major health issues like 300 million expected by 2050, of which 200 millions will end up with chronic ailment, and 1/4 of them at least would require some kind of admission or some kind of medical care of a very active nature. And as you know, healthcare expenses go up. Like for example, 60% of healthcare expenditure occurs after the age of 65. So when you have a huge population which is old, you will be having a lot of drain if you continue with the present system on healthcare resource, which by the way is very, very scarce. Therefore, the scenario in the elderly care is that the norms are changing. We're no longer having the norms which we followed in the family 10, 20, 30 years ago. We believe in a micro system family. The parents sometimes are not with the children, or the parents have their own issues, are in old age homes or in their own homes, and the children are working elsewhere. And the so-called epidemic of chronic ailment, the moment you cross 60, whether you like it or not, you inherit a whole lot of old age related problems. If nothing, at least their weaknesses, their osteoporosis and their muscle dystrophies, etc. And primary care is not even. Let's accept it. It is very, very grainy across the country. Some areas are badly represented, whereas some areas are extremely well represented. And Tier 2, Tier 3 cities, hardly any representation at all. And you can see majority of the people whom we cater to are 65 years and above, so geriatrics is something which you can't wish away. And unfortunately, every day, as time progresses, people have to succumb to their illnesses or age, and the end of life care is very, very important, especially in areas like oncology and nephrology. And there is a stated preference of all our elders to die at home, but do we have the facility to do that? They land up in hospitals, land up in nursing homes. Therefore, the cost of this kind of care is phenomenal in India when compared to other cities, and there is a crying need for us to reduce this particular cost and make everybody feel comfortable. A gamut of services, like I mentioned before, which can be opened up for the geriatric sector. And the next example I'm going to talk about is diabetes. And this is something which is very, very phenomenal. As you very well know, we can have about 70 million diabetics by the end of 2025. No wonder India is called the diabetic capital of the world. We have various theories to say. There's a beautiful article which came out 3 or 4 months ago saying how our poverty and our bad food habits made us assimilate whatever we eat, and today, because of the sudden affluence we are seeing, people are accumulating more carbohydrates and foodstuffs that we eat and ingest, and therefore diabetes is a very natural byproduct of this particular phenomenon. Be it what it may, more than 50% of people with diabetes remain undetected in today's world, and that's because they believe that there are no symptoms, so why should I bother? So diabetic care leaves very much to be desired, and what we can do in home care or in primary care is that change this particular scenario totally. We know pretty well that the prevalence is about 40 million today, of which about half of them will be diagnosed, and amongst those diagnosed, about 10 million perhaps take some kind of treatment, but unfortunately, 1/3 of them will adhere to whatever treatment we prescribe. Therefore, from about 40 million to about 3 million taking treatment leaves a very, very bad gap in between. And we know that with every passing phase of neglect, the cost of treatment goes up and the cost of healthcare goes up. And what are the consequences? We've seen very alarming statistics in this paper. We can see 20+% positive with end organ damage, with retinopathies, with neuropathies, with coronary artery disease, which once again means doom and shortened lifespan for these people. There is a concept called clinical inertia. From the patient point of view in India, the treatment is perceived costly for an asymptomatic situation. There is genuine or otherwise lack of accessibility to healthcare services. Follow-up is inadequate. Follow-up has always been an inadequate problem. That's why our healthcare statistics are always skewed. Low priority for health for whatever reason. Indifference, comorbid conditions contributing to their indifference. And to a great extent, there is a lot of dependence on children or on caregivers, which makes the system a little more complicated. And it is not just the patients who are to blame. The medical profession partially also has various barriers in treatment care. The medical training in a hospital, typically we're trained to do acute care, not so much for family practice of a general care or for anything which is conversational, long-term, is generally discouraged upon. Somebody was talking about it in the morning. We're all trained towards doing high-class, top-class training in hospitals, and once our students go out, I'm sure there are 3 or 4 of my students sitting in the hall here who will endorse what I'm saying. When we go out, we realize the gap between our training and the gap what we're doing today in the real-world situation. Treatment of acute diseases are always very rewarding, both academically and otherwise. Most of the clinical workload in developing societies is due to acute infection and therefore not much importance for the chronic infections. Even nurses today find treating acute illnesses far more interesting. So there is a mindset change which is required, and that perhaps will change the way we look at this particular population. Why diabetes? Let's take any other chronic ailment, hypertension, heart disease, cancer, dementia. There's a crying need for us to develop a different model than what is existing today. And together, general practitioners, family practitioners, and home care developers can make a difference. We have specific programs for various ailments. So I say about 60% of what can happen can be treated at home, some of them being orthocare, post-acute, or maybe chronic orthocare. We enable our elders by doing what is called fall prevention programs, make sure that they are the biggest proponents of the Tai Chi kind of exercise, fall prevention, elderizing a home. We found that exercise very, very useful, and we find that they are very, very receptive towards learning these things because they don't want to be dependent on anybody. They have osteoporosis, and simple exercises and a mind to do something to improve their health goes a long way. Stroke rehabilitation is another area. Oncology care is a huge, huge segment in home care. We are doing chemotherapy at home, especially the simpler ones. We are doing bisphosphonate infusions at home. We are doing fentanyl patches at home. We are doing chemo port flushing at home. There is absolutely no need for somebody to come to hospital to do that. Palliative care is a huge segment, not necessarily in oncology, but in any chronic and end disease situations. We draw up a very simple care plan, putting a combination of physiotherapy, nurses' visits, doctor visits, and so on, and then make sure that we have a very robust backbone, electronic backbone, which will remind everybody concerned about the impending appointment. We fix the appointments, and we go on a predetermined schedule to the patient's home, having informed him, her, the patient, the daughter, the son, and get an outcome measured from the visit and load it immediately onto our webpage. So this is a typical cycle which we follow in terms of executing a long-term care plan. So there's no question of slip up, there's no question of saying I missed my appointment, everything is preordained in terms of the care plan, and the patient doesn't have any excuse because we go knocking on their doors once a day, yes. So we have a schedule to follow and thereby make sure that the compliance is better. So moving from the unorganized towards the organized, and moving from the tertiary to the non-tertiary care, we notice that the on-demand non-tertiary care, read home health care, read primary care, has gained a lot of importance. All right? And we are not on a collision course with the hospitals. No. On the contrary, the hospitals want us. We have tied up with all the major hospital chains in the country for the simple reason that once they leave the portals of the hospital, they are not sure what the patient is going to go, where the patient is going to go, what the patient is going to take. They'd rather have people like us who they know what we can deliver, they partner with us, they are our B2B partners, and we follow them up at the patient's home, deliver reports to the hospital. Therefore, there is a connect between the hospital and home care. So much so that all these major hospital chains are wanting us to partner them and help them in their home care delivery. Therefore, continuity of care is maintained, compliance is maintained, and the information gap is not there. All this is not possible if you do not have technology. I have a lot of friends who thought of this idea but did not see the light of the day for the simple reason that you cannot scale an operation like this, which is so very manual, without electronic help, without tech help. We have web-based applications. All our clinicians carry a smartphone which has an application in it. They have reminders as to when they should go where. We geofence our clinicians so that they don't have to travel more than 8 to 10 kilometers to make a visit. Therefore, a whole lot of parameters are keyed into our web-based application and our ERPs, and the smartphone concept where you can immediately upload a clinical situation, you can take an ECG at home, and you can upload the ECG to our specialists at the back end who can immediately interpret it, ask for an admission, or consult the clinicians or the specialists in a hospital. Therefore, everything happens real time, and in about half an hour's time, we're able to say what exactly is wrong or make sure everything is right. Technology helps us tremendously in this and also helps us to scale, because we are sitting in Bangalore as headquartered and we have 24 cities across the country. It is very difficult to manage this without our tech support. These are our vital statistics, ladies and gentlemen. 24 cities, 2.5 years' time. We are the largest and the fastest growing healthcare company, so obviously we are doing something to disrupt the medical phenomenon in the country. We have 3,600 plus people and counting. We do 60,000 visits plus per day. We have partnered, this is our testimony to our good work. We have 50 plus major hospital chains who have partnered with us and say, we are the preferred home care partners. And what is left now, as I was telling Mohan and Raman, we need to, as family physicians and us, we need to join hands and see how effectively we can optimize our functioning so that we can really make a difference in terms of delivering this particular simple phenomenon, so-called quote-unquote simple phenomenon, home care, effectively, and bring in a whole lot of segment of people who otherwise wouldn't have sought medical health onto the mainstream. So, like they say, you think out of the box, I say you think out of the hospital. Together, we can do a whole lot of difference, at least in about 50% of these population. Thank you very much for your attention.